Dr. Benson.
Hi guys. So for those of you that are here, welcome. If you want to do some jumping jacks to get warm, feel free. I'm freezing in here. Those of you at home, I hope are more comfortable. So when I was thinking about, when we talked about me doing this a couple weeks ago, this was before everything got crazy, and then I was like, well, maybe you shouldn't give it, you can give the lecture time up for something that's more applicable. But I realized that it's actually a good time to talk about some of this stuff because while nobody wants to focus on charting because it's mundane, and this is like hopefully, very hopefully, a once in a career type of pandemic. Charting is a necessary skill. It has to be practiced the same way that intubations and resuscitations and central lines have to be practiced. I did not practice it when I was a resident here, and I learned kind of the hard way after I got out and started practicing that there were lots of skills that I didn't learn. So time management is really important to what we do in emergency medicine. EMRs have gotten, you guys are on Epic now, so you know that it's great, but it's also very click heavy. So the more you can use your training time to build in your skills, the better off you will be when you leave here. Some places you'll find will stagger shifts, and they'll allow you to have to stop seeing patients at a certain hour before the end of your shift because somebody new comes in to give you time to wrap up. A lot of places don't do that, so people end up staying late, and your time is very valuable. So you don't really want to finish your shift, whether it's an 8-hour or 10-hour, 12-hour shift, and then spend another hour or 2 or 3 wrapping up to finish your notes. We're going to talk a little bit about practice models and how this impacts you, but you want to be able to be done with your shift at whatever time you're supposed to be done and leave after your sign-out time. So that's an important skill to learn. It matters because for lots of reasons. Number one, if you didn't document it in your chart, it didn't happen. So Vegas rules don't really apply in emergency medicine. In other words, what happens in the ED should not stay in the ED. You need to take, your documentation to reflect what you've done so that the providers who end up taking care of the patient know kind of what happened. Number two, the reason it matters is to be a good citizen. So within the House of Medicine, job security is important. No medical director wants to talk to you about the fact that you didn't complete your charts. So one of the metrics, when I worked for a corporate medical group, one of the only metrics we shared with physicians every month was this metric called revenue lost based on charting. So an email would get sent out to the whole group, and it would talk about how if you hadn't done your chart, they weren't able to bill that chart, and so you basically are costing them money. So you don't obviously want to be on that list. It's also healthy practice. I think when you leave your shift, you want to mentally, you're going to carry home the emotions that you carry home from the patients that you care for, but you want to be done with remembering, was it the guy's left ankle or the right ankle? Which side was I standing on? All that stuff weighs you down, and you really don't want to carry that with you. So if you've got it all in your chart, you don't have to remember it for the next day or the next shift. And then the last reason, oh wait, no, one more thing before we switch is this eat the frog philosophy. I don't know if you guys know that philosophy, but it's a Mark Twain quote, but I think it actually is a French philosopher, and it probably sounds a lot better in French than it does in English, which is eat the frog. But there's this idea that we all have tasks in front of us that we don't want to do, whether it's the rectal exam and the confused patient where they're in the hallway and you got to move them to a place and whatever. There's all these things that prevent you from wanting to do it, or they're challenging or they're difficult. But if you do those things first in your day or in your shift or when they present themselves to you, you actually have this sense of accomplishment, and then you're much more productive. So if you keep putting something off and you're putting it off and you're putting it off in your shift, and whether that's your chart or an exam or whatever, you end up getting kind of mentally weighed down by that thing that you have not done. The second part of the phrase is, so if you have a frog to eat, it's best to eat it first in the morning. And if you have 2 frogs to eat, it's best to eat the bigger one first. So in other words, the more challenging thing that sits in front of you, get that thing done, and then you'll be more prepared and more able to do the next things that come along. This is no longer clicking. What did I do wrong? Oh, I just do this. Wait. So did I skip one? Oh, this one, yeah. So, and the third rule is self-protection. So the burden of proof in malpractice cases is actually quite high. And if your chart accurately reflects what you did and the timeliness with which you did it and what your thought process was, that actually helps to defend you. A colleague of mine at a place where I used to work, he and his wife were expecting a baby, doing all the regular prenatal stuff, had like all the anatomy ultrasounds, were told everything was normal. And when that child was born, it turned out he had a very significant cardiac lesion that had not been diagnosed. And when they sort of, investigated into it, they were able to show through IT records that the radiologist who had read this study had the images loaded for exactly 7 seconds before he clicked that it was normal and he or she clicked that it was normal, went on to the next study. They ended up suing, and they were, based on that IT technicality, were able to show that the radiologist had not done his job. And they did studies where they showed it takes exactly 7 seconds for all the images to load. So he basically opened the study, waited for it to load, clicked it, it's done, and that was it. And so this IT stuff becomes important. If you write your chart, like, so you did a shift, it was busy, you left, you came back 4 days later, because that's when your next shift was, and they'll have all these charts to do. It's going to show up that electronically that you didn't write that chart until 4 days later. And really, how well did you remember that patient encounter? How well did you remember the timing? So the IT stuff, while EMRs are good and they help us improve our documentation in some ways, they can actually hurt you. And so you want to be kind of thoughtful about that. So how do you actually get paid? How do you take that encounter of auscultating a patient, and how does that turn into dollars that you get to spend on things that you like or need? So on the date of service, you do a chart that shows your history, your review systems, physical, your decision making, all that stuff. And then what happens is that gets made into a chart, which gets completed, meaning it gets signed by you or your supervising physician or whatever. And then it gets transported. Now that can be electronically transported, which means it gets batched into a bunch of files that then gets sent to a coding company, unless there's in-house coding that's done, and every place is kind of set up a little differently. The coder then takes your chart and they assign a code, and they do some demographic verification. The patient is who the patient says they were. And then the bill gets dropped. And the chart actually doesn't go to the insurance company. It literally is like a list of the patient demographics and the codes assigned. The insurance company can always ask to audit a chart to see the actual charting, but they don't see what, the insurance company doesn't see what you wrote. They see a code that a coder has assigned to your chart. And then the bill gets sent and to the insurance company. Ideally, that should be the gold standard for bill drop is actually 4 days. So think about all the things that needs to happen in that 4 days. You have to see the patient, you have to do your documentation, it has to get verified, it has to get sent to the coding company, it has to get coded, and then it has to get sent to the insurance company. And that's all supposed to happen in 4 days. And if you do your chart 4 days later, you're already behind the 8 ball, right? So to speak. Then there's this thing called the Dunning cycle, which basically, so it's a lot of noise for insurance companies to get bills submitted, every 20 minutes the next time the coder has a chart completed. So what happens is they fall into cycles. So bills get submitted weekly. Different insurance companies have different days where they basically receive bills. So like Tuesday, Blue Cross Blue Shield, that's their day where all of their bills come in. Wednesday is Medicare typically. And then there's a turnaround time for those insurance companies to then pay, and you want that to be electronic. So you want your bill to be submitted electronically, and then you want the funds to come back to you electronically. Medicare on average takes 21 days to pay a bill. Medicaid on average takes 30 to 90 days. Workers' comp takes 180 days. So remember, you've laid out the service. You've basically extended credit to the insurance company. You've performed the work, and now you're waiting for the money to come in. And 180 days is a long time. You're not waiting 180 days to get paid, right? So somebody is paying you, and it's basically just this one huge line of extended revolving credit. But your chart plays a very important role in that. So you really got to try to get your chart done so that the payment is not waiting on you. The take-home point for this is do your chart in real time. Okay, it's important. You have to do it. It makes you a better, more covered physician, and it helps kind of the whole healthcare system be more efficient. I wanted to talk a little bit about payment models because I think a lot of times people don't really know this stuff. So there's a salary model, right? You're an employee of either a health system or like a university system or whatever, and there's an annual salary. So it's based on 36 hours of a work week. And some of that it can be 100% clinical time. It can be half clinical time, half protected time. And the protected time is basically the department thinks that you offer a value to the group that isn't necessarily seeing patients. So that's talks and research and sono and all these other things that broaden your education and broaden your expertise as a physician. And that typically is an annual salary that you get paid out wherever their pay system is, once a month, every 2 weeks or whatever. And the thing is, when you talk about how income affects physician behavior, I've learned that there's really only a few things that you can do as an administrator that really change physician behavior. And one of them is to change salary. People obviously don't like that unless it's going in the up direction. And changing schedule is the other thing that I found that will shift physician behavior. So the emphasis here, if you're a salaried employee, is that you kind of have to count on the fact that the physicians want to see the patients in a timely fashion, and they want to make sure that the patient gets good care. As opposed to an RVU system where you literally, this is like the sort of bang the rack mentality where you get paid based on the patients that you see in your documentation. So in this case, what happens is the government assigns what the value of one RVU is, which it's called a relative value unit. So these are some common ED codes for like a level 3 visit, a 99283. That's worth 1.34 RVUs. The government says that an RVU is worth $37.89. So if you see a patient and say it's a super complicated case, but you have kind of iffy documentation, you don't do a good review of systems or whatever, and that case should really bill at a level 5, maybe even with critical care, but your charting only reflects a level 3, that's how it'll get documented. And that's revenue that you've ended up not claiming for yourself or not claiming for your group, okay? So that's you can do the math in your, or whatever in your head, but you know, 38 bucks times $1.34 is about 50 bucks. If that chart really should have been a level 5 with critical care, that's what, 7.2 RVUs. That's a substantial difference in potentially income for you and for your partners. And then the last model, there's other things, these are kind of the overview, is like a small democratic group. So that's where there's a group of physicians, they have a contract with the hospital, and they basically profit. So you can usually buy into the group after a certain number of years, certain number of dollars, and then you share in whatever the revenue that the group brings. So if you are in a small democratic group and you make that mistake where you're quoting or you're doing a chart that's only documented a level 5 when they're level 3 when it should be a level 5, you can imagine the partners are going to have something to say to you because all that stuff is tracked because you're impacting other people's bottom line. The other thing I wanted to mention, because I don't think I really knew this in residency, is that there's kind of 2 types of billing. There's physician billing, which is the bill that gets sent for you, for the consultant that you call, for the radiologist if you order an imaging study. And then there's the facility billing, which is what the hospital sends out. And that covers a lot of stuff. It covers the lights, the electricity, the nurses, the angiocats, if it takes you or the nurse 2 or 3 times to stick a patient. The gauze, the transporter, the heating, which clearly is not on in this room currently, security, the IV start kits, the lab tech, the blood tubes, the PACS monitor, the radiology tech, CT scanner, all that stuff, the little grippy socks that are in the drawer sometimes for patients, like that's all part of the facility billing. So when you, so we talk about what the physician documentation is for the physician billing, but there's all these other things that if you document that these things occurred for the patient, like IV fluids, for instance, ordering IV fluids. One of the biggest sources of revenue for a lot of hospitals is the giving of the administration of IV fluids. They bill a tremendous amount of money for that. And if you don't order the fact that the IV fluids, in theory, the nurse should say, hey, doc, can you put in an order for that? But at a place that I worked previously, they did a little study project where you have to have start and stop times for all of the fluid, and the nurses are responsible for putting that in, but they weren't doing it. And we did a little study where we showed how much revenue was lost, and it was a tremendous amount of money. Like over a week, it was like 50 grand an IV fluid start and stop times and whether or not the fluid had been ordered in the first place. So I know like nobody wants to think about medicine in a financial way. We're all here because we want to help people and we want to do the right thing and make the world a better place. But in order to have the funding to be able to have enough staff to do that, you have to justify the work that you do so that you can be compensated for it. So the take homes that I just wanted you to get out of this lecture are that it's super important. You have to do your charts in real time. You have to do your charts in real time. I'll say it again, you have to do your charts in real time. Dr. Holt sends out that list. It's a week after the fact, and the fact that there's names on there, you know, where there's like multiple, like 20 charts, 50 charts that aren't completed, we can't have it. So you got to get your charts done. Your chart is your chart completion is the first step of many steps in the very complex billing cycle. EMRs are great when they're used efficiently. You should get some good habits. Use macros where it's appropriate so you're not clicking to death in Epic. And write progress notes. A lot of times I'll read through charts for peer review process and I see like, you know, the HPI or whatever. And then there's like this course note that you guys write, which is great. Like the patient came in and this is what they had and this is what you thought. And then the patient gets dispositioned 5.5 hours later, and I have no idea what happened in that time period. I have to go back and look at orders. Well, they ordered antibiotics here, so they must have gotten some information, or maybe they forgot, I don't know. And there's no note to say why that was done. So if you can, every time you contact the patient, you should be putting in a progress note, like, oh, the nurse at 12:35, the nurse called me to room 7 because the patient was now complaining of shortness of breath and the SAT had dropped, and I did blah, 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 blah thing, as opposed to at the end writing that the patient got, you know, came in for something else and then got intubated for respiratory failure. Like, how did those two things happen? I have no way of knowing when I go back and look at the chart. And it's not just me, it's if there's a bad outcome and there's a suit, it looks like nothing was done for the patient. So that's it. I think that's all I had. You guys have any questions about that? If you do, let me know. You will get emails from me about charting sometimes. It's not to, it's mostly just to try to improve your documentation, okay? So if you get an email from me, if there's a question about something, try to get back. I'll always send it to your downstate account, so there's no HIPAA stuff, but I'll try to send an email to your Gmail account as well, just so you know it's there in case you don't check that every 15 minutes like I do. All right. Cool.
All right, everyone. We are going to do Sarah's senior lecture here in a second while I pull it up. Just take a moment.